Well, thank you very much, Philippe, for the invitation to come here. And I'll just call up my slide set, if I could. I'm representing a large group of people speaking about this cohort today. It is called the Canadian Alliance for Healthy Hearts and Minds. And my two co-PIs are Dr. Matthias Friedrich from the Montreal Heart Institute and Jack Tu from ISIS in Toronto. And 3 years ago, we, as a group, answered a call for proposals to build in some cardiovascular questions to existing cohorts in Canada, most notably the Canadian Partnership for Tomorrow project. And you heard earlier from both Philippe and John Spinelli about two of the cohorts that make up CPT. So our goal was to add in some important unanswered cardiovascular questions to existing cohorts. And when we look across Canada, there are some important unanswered questions. And the first is that across the country, as we go from east to west, there is a gradient of cardiovascular disease. So if you can see here in the dark areas, we have a higher cardiovascular mortality, and the lighter areas, a lower cardiovascular mortality. And so there is an east to west gradient that is not explained by the burden of risk factors alone. So when we adjust these data for the burden of things such as diabetes, hypertension, obesity, the gradient still exists. So one possibility is there is differential access to health services and differential treatment of risk factors when they exist. We also were interested in trying to identify individuals who were at higher risk of cardiovascular disease, similar to the way Tom is approaching cancer. So we have the usual risk factors that are incorporated into something called the Framingham risk score. There are many different types of risk scores. That's scoring things such as cholesterol, blood pressure, diabetes, body weight, etc. But there are new technologies, imaging modalities in particular, where we can detect subclinical disease. And the question is, if we can detect disease early, perhaps we can prevent it and prevent subclinical disease from becoming clinically apparent. Now, one of the research studies that we've done led out of McMaster is called the InterHeart Case Control Study. This was a global case control study in which 27,000 individuals, half cases, half controls, from around the world participated in determinants of myocardial infarction study. And we observed that there were what we call 9 modifiable risk factors for MI, and you can see them here. They're not surprising. The usual suspects such as abnormal lipid profile, smoking, diabetes, hypertension, a measure of obesity, in this case abdominal obesity, psychosocial stress, and some lifestyle factors that are associated with MI. And altogether, these 9 risk factors account for 90% of the population attributable risk. So we wanted to use either new risk factors or discover new risk factors or new imaging modalities to try and add to the prediction of existing risk factors. In the InterHeart study, what was very interesting is to look at the overlap of risk factors comparing cases to controls. One might expect that the cases would be on one end and the controls would be on the other. You can see that there's a lot of overlap between the cases and the controls. And in fact, the majority of people in the population have some cardiovascular risk factors. In our study of 27,000 people, only 43 had 0 risk factors. So the point being, cardiovascular risk factors are ubiquitous in the population and are not enough to allow us to discriminate between who will become a case and who will remain a control. So the objectives of our Canadian Alliance of Healthy Hearts and Minds were threefold. One was to try and understand what we call the causes of the causes. What are the upstream environmental causes of those 9 risk factors? And to do that, we're looking at some of the contextual risk factors, socioeconomic status predictors of risk factors. The second objective was to look at some of the unique patterns of region, so the contextual factors that promoted risk factors, as well as access to health services and treatment of risk factors when they exist, not only in the general Canadian population, but to include high-risk groups, notably people of Aboriginal origin, so First Nations people, Métis individuals, as well as certain high-risk ethnic groups, such as people who originate from India and people of African origin. And then the third objective, as I mentioned, was to use magnetic resonance imaging to try and pick up subclinical vascular disease or subclinical disease that are predictors of risk factors such as diabetes using MRI. Now, the design of the cohort is to include individuals, men and women, between the ages of 35 to 69, who come from many other cohorts. So we call the alliance a cohort of cohorts. So as I mentioned, the 5 CPTP cohorts are existing cohorts from which we would like to draw participants and have them undergo the alliance protocol. As well, we have some external cohorts, and we are creating a new Aboriginal cohort. And when participants come in and agree to participate in the alliance, they have a number of measurements seen here. So the usual assessment of cardiovascular risk factors, family history, etc. Some physical measurements, blood pressure, waist to hip ratio, a measurement of diet using a food frequency questionnaire, physical activity, and a blood sample. And then our big test is using the MRI. Now, as I mentioned, our aim is to recruit close to 10,000, 9,700 men and women, and you can see the different cohorts from which we hope to draw individuals into the alliance. So shown in blue would be the proportion of individuals we aim to recruit from existing cohorts, and you can see the Aboriginal bar is a brand new cohort where we're trying to recruit 2,000 Aboriginal people from 10 reserves across the country. And if we look at the map of Canada, you can see there's fairly good representation from east to west across the country, including our Aboriginal communities, which are national. I should have a better look at that in a moment. Now, contextual factors are what I referred to earlier as representing the causes of the causes. So what are the upstream factors that may influence our diet, may influence how much physical activity we do, and ultimately are a key determinant of whether or not we're hypertensive or not, diabetic or not. And up until now, not many cardiovascular studies have done a community-wide or a contextual assessment to try and determine the influence of the community factor on the risk factor. And I'll show you in a moment which domains in the contextual area we're focusing in on. So some of the unanswered questions I mentioned are the east to west gradient, the contextual factor influence, the prevalence or burden of subclinical disease of the brain, heart, and abdomen, and also the important issue of access to health services. Does it differ from east to west? Does it differ for different ethnic communities, in particular Aboriginal communities? Now, it's an interesting era where we have cardiovascular risk factors well characterized and much research in the area of cancer. And more we're seeing that there are overlaps between risk factors for non-communicable diseases. And shown here in the Venn diagram, you can see some of those factors. And one of the most pressing shared risk factor is the increase in obesity, in particular central obesity and its associated risk factors, such as abnormal lipids, abnormal glucose, and sometimes abnormal blood pressure. So this metabolic syndrome is increasing worldwide and is likely a risk factor for some cancers, such as breast, prostate, and colon, as well as it is a known risk state for cardiovascular disease. Now, contextual factors, as I mentioned, involves an assessment of the communities in which people live. In Canada, we're a large country. We have highly populated urban areas and then vast rural areas. And trying to characterize these communities is challenging. The particular areas we're focusing in on will be the built environment, so what influences activity, the nutrition environment, so access, affordability, availability of certain foods, be they healthy or unhealthy, the tobacco environment, so what are the bylaws and the prices of tobacco products, how closely are they regulated in different communities across the country, and the social environment. And so those will be individuals' family environment as well as their social connectedness. And although in some urban areas you might think that 3 of these factors are pretty similar, activity, nutrition, tobacco, in the rural areas, and in particular in Aboriginal communities, there are wide variations. So, for example, one of the reserves we're working with near Hamilton, the Six Nations Reserve, the largest reserve in Canada with 10,000 people living on it, their #1 industry is the production of cigarettes, Grand River Tobacco. So they have over 150 smoke shacks on the reserve and a great exposure of individuals to tobacco with no regulation in terms of selling to minors, and they're sold at a low price. So the tobacco environments and these other environments do vary significantly, and we hypothesize they strongly influence the prevalence of risk factors across the country. The health services data we will assess in 2 ways. One way is to ask individuals the last time they went to see a doctor, the last time they were screened for certain conditions, the last time they were prescribed a medication, and did they fill the prescription and take it. So that's at the individual level. We'll also be able to use record linkage if individuals or participants in the study provide their health card number to actually link to see objectively how often they went to the GP and what services were rendered. And then we can look for common conditions if health services vary from community to community and from east to west. So record linkage using health card numbers is a very important way for us to obtain health services data as well as follow-up data in terms of the development of incident events such as cardiovascular disease and cancer. And my co-PI, Jack Tu, who's based in Toronto, has access to a number of data sets, not only mortality and cause of death, but has the ability to link into the drug utilization databases as well as social services database. The challenges is because this is a national study and each province regulates record linkage differently, is to try and perform record linkage in a national cohort where there are different provincial rules. So that is an ongoing challenge for us. Now, coming to the MRI, this is a point-by-point representation of why we think MRI is better than other imaging modalities. So I'll bring it up slowly here. Now, we know that magnetic resonance imaging is one of the safer modalities. It doesn't expose individuals to radiation. The limitations have been that it's expensive to do and it's difficult to take to the population. For the most part, the population has to come to the scanner. However, the image quality is superior to CT, and certainly its sensitivity to pick up subclinical disease is optimal. Now, as I mentioned, we have fixed sites across the country where we invite participants in the Alliance to come and have an MRI scan. But we also have a mobile MRI that we can take to remote communities. So this is especially important with the Aboriginal population. Many of them are remote and we couldn't bring participants in. So as you can see here, this mobile truck is able to go to different communities. The main limiting factor is to find a nice flat area and appropriate voltage of 480 volts to plug this machine in, and then we can run it. And so we've had experience now with 2 Aboriginal communities where we've taken the mobile MRI to the community and we were able to scan individuals, not without some challenges. In British Columbia, we were hooked up to the hockey arena in Hazelton, and participants were coming through, all was going well, until BC Hydro cut the power supply because the arena hadn't paid its bills. So that threw a wrench into our schedule, but we were able to get a generator there and power it by diesel to finish the recruitment of that community. So there are challenges for sure, but it is possible, and thankfully the quality of the scans using the mobile MRI was excellent. Now, we have two types of protocols we call the regular or short scan and an extended scan. Thus far, the majority of subjects have undergone the regular scan, but we have started at the Montreal Heart Institute with the extended scan. You can see the different measurements we can make with a regular scan. It's pretty good. We can look for subclinical disease in the brain, so the so-called silent strokes, microbleeds. We can look at cardiac abnormalities such as regional wall motion abnormality and other masses. And in the abdomen, we're interested in looking at visceral fat and fatty liver because those are key determinants of the metabolic syndrome as well as type 2 diabetes. With the extended scan, and this means that patients receive an intravenous infusion of gadolinium, contrast agent, we can see much more, but it takes longer and it is more expensive. So the majority of our scans will be the short scan, but we'll have a subset having an extended scan. And you can see some of the subclinical measures that we'll be looking at and the outcomes that they predict. So white matter lesions predicting cognitive dysfunction, and in this study we have two measures of cognitive dysfunction, the digital substitution or DSS test, as well as the Montreal Cognitive Assessment or MoCA. We have a number of other measurements that we pick up subclinically and how they're related to MI, stroke, or other cardiac disease. Sorry, that's a repeat. And in terms of our power, we came up with 9,700 to really give us the power to look at the prediction of subclinical findings on MRI, predicting incident cardiovascular events over a 5-year follow-up period. So with our 9,700, we have good power to look at things such as regional wall motion abnormality on MI, or subclinical or silent stroke on real stroke, and fatty liver and visceral fat as a prediction of diabetes. And ideally, if we can over-recruit the high-risk ethnic groups for this condition, we'll have power to look within these ethnic groups. So to summarize, the Alliance of Healthy Hearts and Minds is a cohort of cohorts. We're bringing together 7 existing cohorts, as well as creating a new Aboriginal cohort to try and understand the causes of the causes, the access to health services, as well as subclinical predictors of cardiovascular disease using MRI. In terms of our updates, you can see we've got certain recruitment targets set for various cohorts across the country. We have about 890 subjects recruited thus far, and they're poised to get a number of cohorts up and running soon. In terms of our Aboriginal communities, we aim to have 10 up and running. We have 4 actively recruiting, as I mentioned. In BC, in Alberta, we've taken the mobile MRI to those sites, and in other sites that are close to urban areas, such as Six Nations near Hamilton and Oneida near Western Ontario, we have participants come to the academic center for the fixed MRI. In terms of our community audits, we're auditing 2,000 communities across the country. Community is defined as the first 3 number letter of the postal code, so the FSA. And you can see we have a fair number of provinces completed, but our 3 biggest provinces, BC, Quebec, and Ontario, will take a little extra time. We send out individuals with a preset audit who go to the community and they make an assessment of the activity environment, so the walkability of the environment, the nutrition environment by surveying grocery stores and restaurants, as well as the tobacco environment based on prices of cigarettes and existing bylaws. So this will be an important resource because we will be then able to characterize the communities from which our participants come into the Alliance, and this will also be available to other researchers who are doing other studies. An interesting and important area of our MRI scan is the percentage of time we actually find what we call a clinical incidental finding, an important finding that we need to inform participants, but also often will count as a subclinical finding in terms of our outcome. We predicted, based on studies such as the UK Biobank and the German Cohort, that we may find a clinically important incidental finding rate of about 3%. At present, we're about 8%. And this is in close to the first 900. So we only report what we call severe structural abnormalities back to participants. So they're very clearly identified at the time of the consent. They're things that either are life-threatening or for which there is a treatment that we are obliged to inform participants of. And this is quite a challenging area and required a lot of input, not only from the magnetic resonance imaging working group, but also from our ethicists and legal group. So to summarize, this is our cohort. This is the map across Canada of our active sites and the sites we hope will become active soon. And it's a big undertaking, but we're hoping we can reach our target sample size within the next few years. So I'll stop there, and I'll be happy to take any questions if you have any. Thank you.
Thank you very much. Questions?
Thanks very much, Sonia. Just a really quick question. With the Aboriginal communities, were you able to consent getting biologics for genomics and genetics?
Mm-hmm. Yeah, so as you know, Philippe, from our standardized consent, they have the option of consenting to provide genetic samples as well as blood and urine. We've had a high level of agreement thus far. I'd say 88% have agreed to give biologics, and they've also agreed to ship them centrally, so we have them at the PHI in Hamilton. The way we've worked the management of data from Aboriginal communities is there's a local working group that makes the decision on behalf of the community as to how their data can be used, and one member of each local working group is part of a national advisory group. So if there's an idea for a study that involves all 10 communities, it would go first to the national group, and each community can decide to participate if it meets their interest.
Dr. Lasko?
Very nice talk. Have you thought about incorporating data from personal activity monitors to make the environmental data richer?
That would be, if we had an unlimited budget, that would be a great thing. We have in other studies used things such as accelerometers. They're kind of new and cheaper these days than they were a few years ago. We found with the personal devices and other cohort studies that there were a couple challenges. We want them to wear them for a 7-day period, and they'd often would only give us 3 days of good data. Or there were a lot of turnover of the devices either being lost or broken, etc. So for this undertaking, we are relying on the physical activity questionnaire called the IPAC. It's the short form IPAC.
Yes.
Sonia, were you surprised by the high level of incidental findings?
I wouldn't say we were surprised. It's something that we have to watch over time, and we have to keep in mind what our age group of the subjects enrolled is. So our plan at the outset was to include about 20% of the cohort with existing cardiovascular disease, and we'd expect that 20% will have a higher rate of some of these findings. And we also know that these findings, subclinical findings, increase with age. So we have to take into account as we go, have we recruited an older group of participants thus far? And I would say, based on my look at the data, we do have an older group, average age of 63 at this time, and we'll need to make sure that we recruit each age decile appropriately. So it's something we watch over time. Thanks.
I just have one little question, and I may have missed it, but in the cancer presentation, one of the strongest factors, at least for the colon cancer, was family history. And I would suspect family history might be of some importance in cardiovascular disease as well. Yep. Is that something that you're measuring? Not that it's necessarily easy to measure, but
Yes, we definitely collected, and we saw also in the Interheart study that a family history of premature MI for men defined at less than age 55, women less than age 65. That was a strong predictor of future MI. And in some of our genetic studies, it looks like family history is a crude surrogate for increased genetic risk. So we definitely have family history of early stroke and MI, and the cancer questionnaire also has a number of family history questions too.
Thank you very much.